and we are being recorded. So today we have 3 speakers. The topic is opioids and pain management. This is batch 3, and we have Dr. Kathryn, Dr. Fatima, and Dr. Romana doing the case, and Layla will do the Bangladesh summary. Thank you, Layla. So I don't know if there's anybody new on. I don't see any new faculty. So welcome to everybody. I see most of you are off video and muted, which is great. If you're having trouble with sound, a good thing is to go off your video. For comments, please use the chat as much as possible. If that's difficult or you can't access that, please feel free to stick up your hand or just unmute and talk. There'll be lots of time for feedback as the session goes on. I think that's it. I think we're going to hand it over now, first of all, to Dr. Kathryn to talk about opioids and pain management. Kathryn.
Great, thank you, Gillian. So I'll just share my screen.
Your voice is a little bit soft, Kathryn.
Can you hear me now?
That's better, yeah.
Okay, thank you. I'll just speak up. Can everyone see my screen?
Yes.
Thank you. So the topic of today's session is going to be pain management with a focus on opioids as well. And we've shared with you already the recordings for the main teaching sessions. There's two, one on pain management and one on pharmacology. And I do encourage you to watch the videos if you haven't watched them, because what we're going to do today is give a summary of some of the information from the videos, but the videos are more extensive. So please do go back and watch the videos after the session if you haven't watched them already. So pain is common for patients requiring palliative care. Pain is a common symptom for patients with cancer, but it's also a common symptom for patients with other chronic life-limiting conditions, such as advanced HIV or organ failure. Pain is a big cause of suffering, so it's important that we treat pain. And untreated pain also leads to mental health problems, so anxiety and low mood and depression. It causes worsening suffering for the person living with the chronic illness, and it causes a decrease in the quality of life. So this is why we're interested in pain, and we're interested in assessing for pain and treating pain. So just a quick review of pain assessment. So there's 7 simple questions that we can remember to ask about for patients who have pain. And those questions are, what is the pain like? Where is the pain? When do you get the pain? The timing of the pain, so how long does it last? Is there any treatment that helps the pain? Has the pain changed with time or with treatment? And what does the person think is causing the pain? Because by asking this question, you potentially get to the person's worries and fears about what might be happening. So we can use some simple pain scales to help us to record pain. And most of you might have come across these before. The most common one we use for adults is the numerical scale. So this is from 0 to 10, with 0 being no pain and 10 being the worst pain that person can imagine. And we ask the person to rate, how is your pain right now? For children, we can use the FACES scale. So usually children 4 years and above will not be able to use a numerical scale, but they might be able to use the FACES scale. And you can see the FACES scale is here, and it corresponds to the 0 to 10 scale that we use for adults. And we ask the child, how much does the pain hurt? And ask them to point to the face that corresponds to how much pain they're feeling. And for very young children, so children less than 4 years or 3 or 4 years, and for adults who are unable to report their pain, either because they're confused or maybe have dementia, or another reason why they're not able to give you pain history and report the severity of their pain, we can use the FLAC scale. And the FLAC scale is here, and it looks at 5 different categories. It looks at the person's face, it looks at their legs, and if their legs are moving, or the position of their legs. It looks at the person's activity, whether the person is crying or moaning, and whether they can be consoled. And you can see each of those 5 categories has a score from 0 to 2. And again, this same scale corresponds to a pain score from 0, which is no pain, to 10, which is the most severe pain. There's a bit more detail. There's a bit more detail on the pain scales in the video. So we're going to talk briefly about pain management, and there's a few key principles to remember when we're managing pain. So we use the WHO analgesic ladder. So we classify pain as mild, moderate, or severe in nature. For patients in pain, it's important to give painkillers regularly. The reason for this is we know that patients who have pain need more analgesia to get their pain controlled than they would need if you give regular analgesia and keep on top of their pain. So it's really important for patients with ongoing pain that we prescribe the analgesia regularly, but also a dose for SOS. So also a dose for them to use as needed if they have pain despite the regular analgesia. We recommend painkillers should be given by the oral route wherever possible because it's easiest for the patient. And oral tablets can be taken at home so they can continue the medication at home. And we need to review pain after we've started treatment because we don't know how much painkiller someone's going to need until we make an assessment after we've initiated analgesia, and we know we might need to increase that if the patient still has pain. So this is the WHO analgesic ladder. I'm sure most of you have seen this or are familiar with it already. So just a quick recap. So step 1 is considered to be mild pain. And for mild pain, we use paracetamol or non-steroidal anti-inflammatories such as ibuprofen. And we can use other medication as well, depending on the type of pain. So most of you will be familiar with using things like Buscopan for abdominal colic. And we can use different types of drugs if we have neuropathic or nerve pain. I'm not going to go into detail about those here, but we can sometimes use some antidepressants and anticonvulsant medication. And these, with other drugs as well, are considered adjuvants, which are medications that are not primarily intended as analgesics, but do work as analgesics in some circumstances. Step 2 on the analgesic ladder is moderate pain. And for moderate pain, we use a weak opioid. And in Bangladesh, you have access to tramadol. So we use tramadol for moderate pain. And we can add in step 1 drugs to step 2, so paracetamol and ibuprofen. And we can add in the same adjuvants. Step 3 is severe pain. And for severe pain, we use morphine usually, or another opioid. So a strong opioid for severe pain. So just a quick recap, this WHO analgesic ladder is intended for patients with cancer-related pain, but also for other patients who are requiring palliative care. So when we're discussing management of pain, we're talking about managing pain in patients with end-stage heart, kidney, lung, or liver disease. So patients perhaps with a prognosis of months or weeks. We're talking about patients with advanced HIV, and we're talking about patients with advanced degenerative neurological conditions, but we're not talking about patients that do not have a chronic illness. We're not talking about patients that come in with, for example, back pain that do not have a serious illness in the background. So we don't suggest you treat, for example, a young patient with musculoskeletal back pain severe with morphine, just to be clear. So these are patients that are requiring palliative care, and we can use these medications for these patients to treat their pain. So just a quick recap of each step. I'm not going to go into detail here. So step 1, we use paracetamol and ibuprofen. And I'm not going to say more about them here. There's a bit more on them in the video. For step 2 of the analgesic ladder, we recommend tramadol. And again, I'm not going to give you detail because this will be covered by Fatima in the tramadol pharmacology, which is the next talk coming. Again, there's more details in the video if you want to hear more. And for step 3, we use morphine. Now, just a quick mention about morphine. So morphine comes in 2 strengths, in two forms. It becomes in immediate release morphine, which is either a syrup or a tablet, and it comes in, or an injection, and it comes in sustained release tablets as well. I know a lot of you don't have access to morphine, so I don't want to talk a lot about it. But just to say, if we have a patient that needs morphine and you have access to it, we recommend to give immediate release morphine regularly. So that will be every 4 hours. Starting dose is 5 to 10 milligrams every 4 hours. And we use the same dose for breakthrough pain, which can be given up to every hour for patients in pain. It would be unusual for people to need that every hour, but if someone's in very severe pain, they might need a lot of extra doses, and we might need to increase the medication quite quickly. If a person is wide awake and alert and in severe pain, you can safely give them an extra dose of the morphine. We can use morphine also in young babies and children. And if the pain is not controlled, we can increase the dose, and we recommend you increase it by about 25 to 50% per increase per each dose. If patients have severe renal or liver impairment or moderate renal or liver impairment, we should decrease the dose by 50%. And severe, we should also think about increasing the interval between doses as well. And just a quick recap on the side effects of opioids, weak and strong opioids. So this includes tramadol, morphine, and other opioids that you might come across, fentanyl, oxycodone. So constipation is the most common side effect. It's very common. So we say always prescribe laxatives when you're prescribing opioids. And depends on what's available, but Senna is a good choice because it's a stimulant laxative, and you might want to add in a second laxative, such as lactulose or Laxena, or Docusate, depending on what you have access to. If you go up with the opioids, we often go up with the laxatives as well. But you'll assess this each time you assess the patient to make sure that they are not constipated and having side effects. Other side effects that are common or reasonably common are nausea and vomiting, but this is usually temporary, and usually after a few days of initiating or increasing a dose. If the person's having nausea, it usually settles down on its own, but you may need to prescribe an antiemetic, and the best choices are metoclopramide, or another option would be haloperidol, which we prescribe at low dose for an antiemetic. We will have a session on antiemetics in a few weeks' time. And another common side effect is drowsiness or fatigue. And it tends to be mild, and it's good to warn patients about the side effects, certainly constipation, but also that they might feel a bit sleepy. They shouldn't be very sleepy. You should be worried if they're very sleepy, but just feeling a bit drowsy after the dose is to be expected. And this is usually a side effect that, like the nausea, will get better after a few days. Now, I refer you to the video for more information on myths about opioids, for managing opioid overdose, which is a rare event, but you need to know how to treat that, and a bit more detail about tolerance and addiction and other things that you may be interested in terms of opioids, because it's a big topic. But I just want to summarize today, because we've just got a short time for this talk today. So in summary, pain is common in patients requiring palliative care. We need to assess the pain, and we can use the simple 7-question inquiry to find out about a person's pain, and a pain scale so we can monitor the severity of the pain at the time, but also after treatment. We use the analgesic Ladha to treat pain for mild, moderate, and severe pain, and we must counsel the patients and family about these medications. So when to take them, what are the expected side effects, what is the SOS dose that they can take if they get pain, and who to contact if their pain is not controlled. Tramadol and morphine are essential medications for managing pain. And we do need to make sure that we are both assessing and managing pain in patients with life-limiting and life-threatening illnesses. Okay, thank you.
Thank you, Dr. Kathryn. I think what we'll do is we'll go on to Dr. Fatima to talk about opioids and the pharmacology of opioids, and then we'll come back to discussion. Just so everybody's aware, there's lots of activity on the chat, so feel free to post on the chat, and of course to speak when we're at the discussion point. So over to you, Fatima.
Great, thank you. I just want to make sure I can screen share. Let's see here. Just one moment. Okay. So many of you may have seen the video already. However, I'm just going to quickly go over some of the slides just as a quick refresher. So my name is Fatima. I'm a clinical pharmacist specialist in oncology and palliative care, and I work with Two Worlds Cancer Collaboration, and I'm from Canada as well.
Fatima, we can see all of your stuff.
Oh, okay. Let's see here.
Just need to click on full screen.
Yes, I've got 2 screens going, so that's what's happening here. Okay, I'm just going to turn that off. Let's try this again. How is that?
We're not seeing anything.
Okay.
So people can look at the chat questions. Well, Tasneem's also posted in Bangla. Thank you, Tasneem.
Does this work if I don't do the
yeah, well, try to go on slideshow.
I think it's going to switch over to that same format.
Well, whatever. That's fine if that's all.
Okay.
Yeah, that goes to your.
Oh,
carry on. I think we can all see. It's okay.
Okay. All right. Okay, so I'm just going to quickly review tramadol pharmacology with everyone. Please take a look at the video for full details and full explanations. So just a quick review, tramadol has both opioid and non-opioid properties. It is a mu-opioid receptor, weak agonist. So it works very similar to morphine in some ways, but it also has a noradrenaline reuptake inhibitor component. So we do see what we call the SNRI antidepressant type of effect. Okay, so with that combination, you get combined pain relief. Okay, now the metabolite is M1, and that's related to CYP2D6. And as you would have read through or listened through the video, CYP2D6 is notorious for what we call genetic polymorphisms. So it really depends on the metabolizer in front of you, basically. How does your patient metabolize this drug to form this particular metabolite, which has that opioid effect? Okay. So another key point is the maximum amount of tramadol recommended per day is about 400 milligrams. So if we were to do a quick conversion of tramadol to morphine, that works out to approximately 40 milligrams per day of morphine. However, as you know, when it comes to palliative pain management, a lot of times we must exceed 40 milligrams per day morphine equivalent. There's also the issue of erratic metabolism. We do not know how our patients will actually metabolize the tramadol into that opioid type of effect. Okay. So the other problem with tramadol is side effects. So serotonin syndrome, which I've provided you with a diagram here that discusses the spectrum of severity. You start off with the blue and you can go into red, which is life-threatening. So therefore, as a result, we do not exceed certain daily doses of the tramadol of 400 milligrams per day. Seizures, which are not serotonin syndrome related, can occur when tramadol doses exceed 100 milligrams per dose or greater than 1500 milligrams per day, which is an overdose scenario. And also the side effects would include similar to opioids, so the drowsiness, the constipation, etc. Okay, so just a reminder of what serotonin toxicity criteria looks like, the Hunter criteria. And speaking a little bit about interactions, so as CYP2D6 inhibitors would have an impact on the efficacy of tramadol that you might use, you must be vigilant of which other 2D6 inhibitors might be used within the patient's care. So a lot of you might be familiar with SSRIs. So there's use of fluoxetine, citalopram, sertraline. You might be using TCA, such as amitriptyline for neuropathic pain. You might be using ondansetron for nausea and vomiting. Okay, so those are drugs that would actually increase seizure risk and serotonin syndrome risk when used concurrently with tramadol. Okay. Within pregnancy and lactation, tramadol is safe, low excretion in breast milk, no adverse effects in infants are known. However, it is recommended to monitor sleepiness for children, and we may see increase in prolactin levels as well. So I believe there should be a document available to all participants that I created, giving suggestions of what is the cause of pain, so what are maybe potential reasons for the pain, and what are recommended alternatives. If you may not have opioids available or you'd like to optimize other therapies, other therapeutic options before going to opioids, I have provided that as a Word document as well. Okay, so overall summary, tramadol is on step 2 of the pain ladder for usually recommended for moderate pain management. It is available in 3 different formulations, oral, IV, and rectal. It is best to avoid it in children, but it is okay to use in pregnancy and lactation. It does require renal and liver dosing adjustments based on renal and liver dysfunction. We do have side effects that we do need to be vigilant about. This drug is not benign in itself. Okay. The CYP drug interactions can result in various effects such as serotonin syndrome, toxicities, as well as reducing opioid analgesic effect overall because you don't get that metabolism in slow metabolizers. So this is just a blown up version of the Word document that I was talking about. So you have the cause of pain, reason for pain response might be identified. And then these are recommended alternatives as well. So these slides should be made available to you for a quick reference. And that's what I would suggest keeping on hand if you ever have any questions. Thank you very much.
Thank you, Fatima. Okay, now let's open it up to questions, comments. There's quite a lot of activity in the chat. And I see that there's some questions about breakthrough dose of morphine. Also, there's a question about the dependence of this drug. So Kathryn, do you want to perhaps talk again a little bit about that, as that seems to come up as an issue? Morphine and dependence?
Yes, I'll talk about that. I'm sorry, the clock's going in the background, so just give me a second and that will finish. There we are. So there is more detail about dependence in the video because it is a very common question when we start thinking about using opioids. So I just want to ask what exactly do you mean by dependence? Do we mean a physical dependence or are we talking about addiction? Dr. Muradal, do you mind to unmute yourself and just share a bit more about your question? I'll just give him a second. If not, I will keep talking. Dr. Muradal, are you there?
Yes, I'm there. Sorry for my network interruption, actually. Electricity is gone, so that's why network interruption. Can you hear me?
Yes.
Yes.
Okay, so I just want to actually ask that we are used that SSRI in case of some of analgesic like amitriptyline. So we are know that analgesic have the basic there's some contraindication also and dependency and the dose of also. So what is the modalities regarding amitriptyline using the, of these patients about the doses and also the dependency?
Thank you. So your
Makes
question is
sense.
not about opioids, it's about amitriptyline.
Yes, it's amitriptyline. Not no, I knew the morphine dose actually, so that's why.
He's probably asking about interaction, Kathryn. So what he should do.
Is it about interaction or is it about dependence?
Interaction and dependence, both actually. I wonder, so concomitant effect on the patient.
Yeah, I'll give a small answer, then I'm going to hand over to Fatima as well for the pharmacology for the interaction part. So for amitriptyline, so for all antidepressant medications, we recommend that you don't stop them abruptly. But we don't tend to see a sort of a tolerance effect, and do correct me if I'm wrong on this, Fatima. We don't tend to see a tolerance effect. So we titrate the medication. There's a all antidepressants have a maximum dose, but we titrate the medication towards the pain. And for neuropathic pain with amitriptyline, a usual starting dose would be 12.5 to 25 milligrams. So a quarter or half of a 50 milligram tablet. And we would usually increase it in increments of about 5 to 7 days until you have an effect on the pain. Usual effective dose is around 75 to 100 milligrams, but not all pains are responsive to amitriptyline. So we usually go up to about 100 milligrams before we decide whether it's an effective drug for the pain or not. If it's effective, we can continue that dose. If it's ineffective, we can wean it to stop again. I hope that helps. Fatima, can I hand over to you for the interactions, and do let us know if we haven't answered your question.
Certainly. Okay, so when it comes to drug interactions with drugs such as amitriptyline that have the serotonin reuptake inhibitor effect, when it comes to taking drugs concurrently like tramadol, there is a risk for this, and it's recommended to not maximize doses in that case. So for example, if you have someone who's already on an SSRI or a TCA like amitriptyline, it's probably best to avoid tramadol, as you don't exactly know how they're going to tolerate or how they're going to react, if that interaction is going to manifest. I've had a scenario where I had a patient on fluoxetine. They were on 40 milligrams a day of fluoxetine, and in the ER, when they came in, the doctor had prescribed Tramacet, which is a combination of tramadol and acetaminophen. Well, after 2 doses, that patient started developing early symptoms of serotonin syndrome, and we had to go in and discontinue the drug right away. On the flip side, I've seen patients who tolerate the drugs concurrently because, they happen to start it before the weekend, and I come in first thing Monday morning and I realize it, and they've tolerated it after I've done my assessment. So, you have that discussion with the physician. So it's very unpredictable. It is best to avoid the combination. And that is one of the reasons we prefer for pain management using morphine, if at all possible, for the type of pain that you're looking to relieve with pain management, as tramadol is very unpredictable in its activity for the most part for that. Does that answer the question?
Yes, thank you. Thank you so much for your explanation. I got it.
Thanks, Fatima. So there's a number of other questions about when can you start morphine? What do you do with patients with renal failure? And do you have to do any biochemical testing prior to starting morphine? Perhaps give that back to Kathryn.
Yep, thank you. So it depends what you have access to. So if you have access to renal function tests and you've got an inpatient, you might want to check their renal function before starting morphine. If you don't, it's reasonable to start morphine and just monitor. The the question about whether morphine is safe or not in renal impairment, it really depends on the degree of renal impairment, okay? And it also depends on what else do you have to treat the pain. So for very mild renal impairment, you might well be using close to normal doses, but I would always recommend you start at 50% of the dose and just monitor a bit more carefully and tell the patient and family about the signs to look for in case they have too much morphine on board. So if they're quite sleepy, you might want to tell them not to hold the next dose and make a phone call and make contact to see if they need to change the dose. Certainly moderate renal impairment, we might want to also extend the moderate severe renal impairment, extend the dosing interval. And in patients with severe renal impairment, you sometimes might just, you might just need to give the dose as SOS. So when they have pain, you take a dose, and it's not ideal, but the best medication opioid for renal impairment is fentanyl or buprenorphine, which most of you may not have access to. So it's a balance, it's a trade-off between the need to treat this person's pain because you can't leave someone in severe pain and the need to be safe. So I would say, yes, you can use it, but reduce your dose, increase your dosing interval, careful monitoring, and just be ready to careful looking for any signs of too much morphine on board. Fatima, do you want to add anything to that?
Sure. Yes, I'll just add to that. So as Kathryn said, we'd be looking for the classic symptoms of opioid dosing that's a bit higher. So the drowsiness, the sleepiness, etc. But also in renal impairment, we are worried about the accumulation of one of the metabolites for morphine. It's M3G, I think, I can't remember. It's a glucuronide metabolite. So what happens with that is as it accumulates, it actually causes neurotoxicity symptoms. So you might actually find, if you get to that point where you see a patient having hyperalgesia symptoms, they're showing symptoms of some delirium, then you know your dosing might require adjustment. And it's likely due to the accumulation of the metabolite from the renal impairment. So that's one of the reasons Kathryn has mentioned, you start low with your dosing, you increase your dosing interval. So instead of giving every 4 hours morphine, you would give every 6 hours morphine, and just closely monitor the patient as well.
Great, thank you. There's a bunch of stuff coming. Mr. Alamona has put, how can we calculate pain management index and use it to assess the adequacy of pain control? Kathryn?
I'm not familiar with the pain management index, I'm afraid. I'm just thinking, who's asked the question? Perhaps you can unmute yourself and share with us and teach us about the pain management index. Is it?
It's Mr. Alamona, who I think is a pharmacist. Mr. Alamona, do you want to unmute and tell us what it is? Okay, so maybe while you're trying to do that, there's some questions.
Sorry, Jillian, I think the pain management index is actually the 10-point pain scale, basically. I'm just quickly looking this up with the brief inventory of pain.
Brief inventory of pain is different.
BPI, one of the instruments that we use, maybe that's what he's referring to.
Okay. Yeah, I did a quick Google search and that's what comes up in the Journal of Pain, that PMI is actually the same as the 10-point scale, so the brief inventory of pain scale.
Good, okay. So there's a few questions about morphine use in the non-classically palliative setting. Kathryn, the difference between general pain and cancer pain, and in any indication to use morphine apart from pain management, i.e. a pediatric patient who's breathless with congenital heart disease. And we will talk about breathlessness later. But
do you want me to say something on that, Gillian?
And perhaps the general pain versus cancer pain and when to use morphine in non-cancer pain. Just expand perhaps on what you said in the talk.
Yeah, so really this advice to use the analgesic Ladha is really for patients either with a cancer pain or with palliative care needs. So patients with life-limiting conditions. Okay, so I think the question was, how do you know when it's a general pain or a cancer pain? And I think it's a very fair comment, actually, because if you don't have access to scans, how do you know if this pain is cancer or something else? And I guess it's going back to your, if I've interpreted correctly, the question, go back to your clinical examination and make your diagnosis. I think in the absence of any suspicion that you've got a cancer or a life-limiting illness, you might want to think about other ways to manage the pain. If it's a sort of a chronic back pain, we don't recommend starting opioids because you'll end up giving the person opioids for a very long time, and it doesn't help them to be on opioids for many, many years for a sort of non-cancer or non-palliative care pain. There's also a question about polytrauma, which is acute pain, and this is different. We do use opioids for acute severe pain, but I appreciate it's very difficult, and in the setting you may not have access to everything you need to diagnose all pains, but I think it's really just get your best diagnosis that you can and try and be a bit sensible to think about whether you think this person really does have a life-limiting illness or whether they have something else going on. And yes, you can use morphine for breathlessness. And as Gillian said, we'll talk to you more about that. I don't know if anyone else in the faculty wants to say more about that. I'm not sure if I've been very clear.
There's some stuff in the people are posting, faculty are posting in the chat. There's responses to renal doses in the chat. And as well, there's a request to share the presentations. Shermy, if you look at your WhatsApp, Megan's posted where all the presentations are, the videos and the others, and where you can look, where you can find them. So I think perhaps in the interest of time, we can come back to the discussion later, but let's move on to the case presentation from Dr. Romana. And are you sharing your screen, Romana?
Yes.
Gillian, can I just make one comment about the pain?
Sure.
Just for the practitioners that are coming, I think when we start patients on morphine, I'm not sure if anyone touched on this, but it's really important to have the follow-up. I'm not sure if Dr. Romana will mention this in her case study, but ensuring that when we put patients on morphine, that we've either scheduled a visit with them, after 3 days, 5 days, whatever is possible, but not to necessarily send them home on morphine and not have a follow-up visit scheduled, or even have given, a follow-up phone number that family or patients can call. I think that's really important.
Great, thanks, Erin.
Thank you very much. Yes, so I'll be sharing a case with you, and I'm not going to the details of the treatment. We will look at the different aspects of pain that we want to address. So let's go into the case. So this lady, one second, let me just exit the full screen. Can you see?
Yes, we can.
Okay.
You were on full screen before though, Romana, and now you're not.
Okay, all right.
There you go.
Yeah, so we are going to go through a case of this young lady, 43-year-old premenopausal lady who was married with one child and a son, and her husband lived abroad at that time. Brother was the main guardian. She presented with lump in right breast in May 2019. In full screen, somehow I'm not getting the. Just a sec. Yes. And so she had this lump, and ultrasound revealed fibroadenoma. Right axillary lymph node was present, which was enlarged. FNSC was done in July 2019. It was suggestive of ductal cell carcinoma. There was no significant family history. Then and next ultrasono also revealed fibrocystic disease with right axillary lymph node enlargement. Left axillary lymph node was also enlarged. Ultrasono X-ray chest bone scan revealed no abnormality. Right breast and lumpectomy was done in August, and which revealed infiltrating ductal carcinoma of right breast, grade 2, margin negative, but one margin was at 5 millimeter and 12 by 20 lymph nodes positive. Pathological stage was BT and 3 MS. Then the slide was sent to India for review, and same came back with the diagnosis of ductal cell carcinoma, grade 3, RB score was 9. And I'll skip this. So she received various levels of chemotherapy. In phase 1, 4 cycles of chemo with AC protocol, phase 2, 1 CT with paclitaxel in India. I'm not going into details. If you have question, we'll answer later. Then later on in November 2019, about 6 months after she was diagnosed, she was admitted at United Hospital. Then was receiving phase 2 cycle 3 adjuvant chemo protocol. After completing chemo and radiation, she received capecitabine 5 cycles, then suddenly developed neurological symptoms with seizures, difficulty in hearing, lost her vision. PET-CT was negative for any distant metastasis, but MRI revealed leptomeningeal metastasis, diffusion restricted areas in left frontal parietal, occipital and right frontal lobes, possibly due to encephalopathy. So most likely leptomeningeal metastasis was the reason. And with all the neurological symptoms, she had severe pain along the right side of her face and had seizure, loss of vision, loss of hearing, and the pain was burning type of pain. Score was most of the time 6 by 10 and occasionally very severe. And they would say it's like more than 10. So she received morphine for her pain along with other treatment, but it was difficult to treat, and we added pregabalin, 75 initially, then she required BD dosage, 75, 12 hourly, then pain was somewhat controlled. So, but she was a single mother. Her husband was not staying with her. Her brother was a guardian. She had one son. She's only 43 years old. And she had all these symptoms. Now, if we think of her pain, I'm just giving you an idea of the areas we need to look into. So when we discuss, we need to look into, you've already you've received the presentation. So physical, mental, psychosocial, and spiritual, each area needs to be addressed in her case when we think of her pain. So if we just think of few areas that we may want to address here, what else could we do? From July to November, we had about 6-7 months to take care of her, and in 2019. And how commonly do you see this? What else could we do? Will you give, sometimes, young patient and family would say, how is she's not eating? What do we do? Can we give TPN? Will you do that? Will you give NG feed? When will you talk about DNR, DNI? And how will you counsel the family? Thank you so much.
Thanks, Ramana. So shall we go step by, if we can maybe keep those questions up, I think that would be helpful, and get some feedback. So should we start with what else could we do for this person, this lady and her family? And feel free to put it in the chat, also unmute and just stick up your hand and we'll try to see you, or unmute and just speak. So anybody have any ideas?
Oh, hello. So
Hello.
in this case, sorry.
Go ahead, Dr. Myrtle.
Go ahead. Yes.
Okay. Now I just want to say that if the first of all we are want to answer, that in this certain time, we need to support if there is the case that presented by ma'am, and it is elaborately told us that she just got every parameter of the treatment, like radiotherapy also from abroad and here also. So why it's spread, we need to be find out that when after that very initially, is that possible to diagnose if the case is very effectively that is spread or not. After that time we just go through that is leptomyalgia spread after this phase 2 therapy. So it's one of the thing, and once commonly is such outcome is very poor actually, and we need to provide the holistic approach of palliative care, thus which lead her to a peaceful end of life actually. And in the scenario we can see that she is very much worried about her child because of she is very young and her child was just very young, so she has a very bigger part of that for her thinking that of what will be happen to him after her left. So it's one of the important things, so we need to be family involvement and also try to make a very good approach to the patient and ask him and ask her that where she get flexible and flexible with his children, with her children actually. So NG feeding, if there is a loss of, so NG feeding, I think it's needed if we need to correct her nutrition. So it's NG feeding is one of the thing we need to do, and counseling family, as I mentioned before. So it is very important. But actually, I have one question about also that after the phase 2 therapy, how would be it will be spread? So it may be spread to leptomyelium. So metastasis, maybe it's not be in proper way we can diagnose that, or something else that very that we after even after we need to choose the therapy after outline the disease prognosis. Because of its very one thing, they are palliative care patient or can this type of patient suffer that everyone has the want to go for surgery, want to go for any kind of therapy, either chemotherapy or radiotherapy, which is really make burden for the end of the life also and also her family. Thank you.
Thank you very much. Actually, if I can just address one thing, when leptomeningeal spread metastasis can happen in spite of good treatment protocol. It is rather rare. And so when we say what else could we do, we usually, we need to treat, diagnose and treat as soon as possible, but sometimes we cannot prevent this even if we do all the possible interventions. So you are saying that, did you address TPN issue? No. NG?
No, I just mentioned the NG issue, not TPN.
Right. So thank you for your comments. Any faculty member would like to add?
So it's Jillian. I'm just thinking, you had the person on, you had this lady on pregabalin, right, Romana?
Yes.
What other, and her pain is greater than 10. If she, I'm wondering what the group thinks about what else you could use for pain management.
Right.
Control her pain. What do people think, and what do you think, Romana?
Okay, let's see if anyone wants to answer that.
So we talked about management. Kathryn talked about management of severe pain. I don't think you mentioned anything else other than the pregabalin, Romana. I might have missed it.
I wanted the discussion to bring that into the discussion. So for pain medication, we used morphine, and by the time she came to us, she had on inadequate tramadol treatment. So we gave her morphine after morphine trial, and then she required uh, about she required initially 10 milligram Q4 hourly, and then we divided into MST, and additionally she required pregabalin. First we started with 75 milligram, then she needed 75 milligram 12 hourly. But then, you know, as you said, when someone says it's more than 10 and family thinks pain is severe, we have to think of all the other areas that we need to address: physical, mental, psychosocial, spiritual area. Now she had loss of vision, and hearing was also losing. She was losing her hearing, so it was very difficult to counsel her. So you can imagine when a young patient is going through this pain and she's having thoughts of her child, she's not able to see. Ideally, we would like to give her some spiritual comfort, some psychosocial comfort. At least she can probably feel her child close to her. So if we could arrange for the child to be with her most of the time, and have her talk to her husband if she's missing him, and try and give her comfort, um, and hoping that she had variable hearing at that time. Sometimes she would hear a few words, and sometimes she would just lie down. Towards the end, she could not hear properly. So it was a very difficult situation for her, and it was difficult to take care of her properly. Although we wanted holistic approach of care, so what we could do is we suggested her child stays with her as long as possible, and we had to also talk to the child and her family members who will be taking care of the child. She was also scared. She used to cry, and she used to um, sometimes ask me who's going to take care of my child before she became, very ill. Thank you.
Thanks, Ramana. So I think there were some other questions. If you maybe could go back, because I think we haven't really discussed the TPN issue. I think we're going to come to some of those issues when we talk about GI, but Tasmin's put in the chat about offering a session to her family and talking to her about wishes and preferences, and who may be her substitute decision maker. That'll be really important.
Yes, I want to add something here. So we never know when a patient goes into a state when they cannot give you consent and cannot really tell you what to do for them. So it's very important to try and talk to the patient and understand how the patient has been before the illness. So we understand the personality, what they would like. Would they rather be home or would they stay at the hospital? Who else did they want around if such situation arrives? And so that when we cannot get her feedback, we can try and treat her to the best of our ability, and do justice to the treatment, to the patient.
Thanks, Ramana. Other comments? Other suggestions about pain management, the holistic management of this lady and her family? Okay. What about the TPN question? Total parenteral nutrition, so giving her feeding by intravenous means. So what did you do, Ramana, in this case?
So she actually, didn't, I mean, she passed away suddenly due to other complications. She had respiratory distress and deteriorated very fast. And we didn't have a very long period to take care of her with TPN. And when we were talking about it with the family, we started, we inserted NG tube for medication because we were thinking of sending her home. And we also told them, because she was young, the reason why we started NG feed and was thinking of TPN was because her husband was trying to get the visa, I mean, sorted and to come and see her, and she wanted that. So we thought, let's try and keep her, going for some time till he comes. So we started all that medication and everything we were giving by NG feed, preparing her to go home for some time. Then we thought if they cannot manage, they can always come back to the hospital. So TPN, we will, in this case, since she wanted to meet her husband and he was trying to come, that's why we would consider at this stage, giving her these NG feed and TPN. But when someone is in that stage, we have to be very careful because it can sometimes prolong their suffering, and it may not be safe also, especially when patient is not in the hospital. So we have to really think of the patient and what is happening to that particular patient when we are thinking of NG feed and TPN, and her age, and what is the goal, what is this patient's goal, and if the patient has any wish that she wants to fulfill, then we do try to keep the patient going for some time. I don't know if any other faculty member has such experience.
Ms. Jillian, I absolutely agree with you, Romana. It's very difficult because, as somebody put in the chat, families often ask for feeding in TPN. We're not going to go into a whole lot of detail with that in the next session, but it's a difficult discussion, and you need to be clear about what the goals are. I think the other thing you need to be clear about is what the conditions will be to stop the TPN when it's appropriate or helpful anymore. Which, any other faculty want to comment about use of?
I'll add before that we will probably teach this group about ethical considerations. So it's very important to keep the ethical consideration in mind when we are deciding on such things as withdrawing or starting a treatment and then withdrawing. It can be very difficult to withdraw after you start something. So a lot of understanding and family counseling is needed for that. And we have to be clear to what we are doing, and if it is really good for the patient at the time.
Great, thank you. Any other comments, faculty or participants, about TPN or about any
So
other?
maybe the TPN, or if the parenteral nutrition were tried to be correct. So it's maybe also a source for infection orientation for the patient, thus she is already immunocompromised severely and hospital staying. So in home, it I think, as ma'am said, it's tough to maintain. So TPN, and it's maybe not a very good, but yes, some sort of patients attendants actually want, because of they think like as I'm working on the Rohingya refugee contest. So some of patients come and it's not either the palliative, so they are providing. So why not you put any saline, so which is make them feel better. So it's one of the thing, maybe they're psychological for their patient attendance. So in these terms, maybe the TPN also maybe the not a good choice, as I think, because of it's also a source for the infection if we are not maintaining in that in home. Is that type of thing?
Yes.
Thanks, Dr. Leno. Okay, if there aren't any other burning questions or comments, thank you very much, Dr. Rahman. I think we'll move on. Lila, could you do the Bangladesh summary for us, please?
Yes, thank you, Jillian. Can you hear me?
Oh, you're very soft.
Thank you. আজকে আমরা যে বিষয়গুলো আসলে জানলাম, আমাদের পেইন ম্যানেজমেন্ট নিয়ে একটা হচ্ছে আলোচনা হলো, এবং প্রথমে আমরা এর আগে আমরা জানলাম যে ব্যথা আসলে খুবই কষ্টকর একটা অনুভূতি রোগের জন্য, ক্যান্সার রোগীর জন্য, এবং যাদের প্যালিয়েটিভ কেয়ার প্রয়োজন তাদের জন্য। সেই জন্য ব্যথা নির্ণয় করাটা আগে গুরুত্বপূর্ণ আমাদের ব্যথা ব্যবস্থাপনার আগে। ব্যথা নির্ণয় করার জন্য আমাদের 7টা সহজ কিছু প্রশ্ন আছে, এটা আমাদের জিজ্ঞাসা করতে হবে। যেমন কোথায় ব্যথা হচ্ছে, তারপর হচ্ছে কখন থেকে শুরু হলো, কিসে ব্যথা কমে, কিসে বাড়ে, ব্যথাটা কি রকমের, ব্যথাটা হচ্ছে যখন হয় তখন কতক্ষণ থাকে। এই ধরনের প্রশ্নগুলো আমাদের জিজ্ঞাসা করতে হবে। এবং আমাদের 3টা ব্যথার স্কেল রয়েছে, আমাদের নিউমেরিক্যাল রেটিং স্কেল রয়েছে, আমাদের ফেস স্কেল রয়েছে, ফ্লাক্স স্কেল রয়েছে। নিউমেরিক্যাল রেটিং স্কেলটা ব্যবহার করা হয় এটা অ্যাডাল্ট মানুষের জন্য, এবং
You're cutting out.
ফ্লাক্স স্কেলটা ব্যবহার করা হয় 4 বছরের নিচে যারা তাদের জন্য। তারপর ব্যথার ব্যবস্থাপনার দিকে আমরা কিছু আলোচনা শুনেছি, এবং এখানে আমরা দেখতে পেয়েছি যে WHO ল্যাডার ক্যান্সার পেইনের ক্ষেত্রে এটা খুবই গুরুত্বপূর্ণ, এবং ক্যান্সার পেইনের ক্ষেত্রে এবং যাদের প্যালিয়েটিভ কেয়ারের ব্যথার চিকিৎসা প্রয়োজন তাদের ক্ষেত্রে WHO পেইন ল্যাডারটা ব্যবহার করা যায়। বিশ্ব স্বাস্থ্য সংস্থার যে পেইন ল্যাডার আছে, এখানে 3টা স্টেপের কথা বলা হয়েছে। স্টেপ 1 এ আছে আমরা দেখেছি যে নন অপিওয়েড, এবং সাথে প্লাস মাইনাস অ্যাডজুভেন্ট দেওয়া হয়েছে। নন অপিওয়েডের মধ্যে আমরা প্যারাসিটামল এবং NSAID এগুলো দেখেছি। স্টেপ 2টা শিশুদের ক্ষেত্রে নিষেধ করা হয়েছে, কিন্তু অন্যান্য যারা বড় রোগী যারা থাকবেন তাদের ক্ষেত্রে স্টেপ 1টা থাকবে। স্টেপ 2 তে আমরা ট্রামাডল দেখেছি, প্লাস মাইনাস অপিওয়েড এবং অ্যাডজুভেন্ট গুলো। স্টেপ 3 তে আমরা স্ট্রং অপিওয়েড এবং মরফিন আমাদের দেশে পাওয়া যায়, প্লাস মাইনাস নন অপিওয়েড এবং অ্যাডজুভেন্ট। আমাদের দেশে মোটামুটি ট্রামাডলটা পাওয়া যায় উইক অপিওয়েডের মধ্যে, এবং স্ট্রং অপিওয়েডের মধ্যে পাওয়া যায়। তবে এই ক্ষেত্রে যে বিষয়টা খেয়াল করতে হয় যে এই 3টা স্টেপে এখানে আমরা দেখছি যে প্রথমে রোগীর ব্যথা নির্ণয় করে ওই অনুযায়ী হচ্ছে এই স্টেপগুলোতে যেতে হবে। যদি অল্প ব্যথা থাকে তাহলে ধাপ 1 থেকে শুরু করতে হবে, এবং যদি মাঝারি ব্যথা থাকে তাহলে ধাপ 2 থেকে শুরু করতে হবে, এবং যদি বেশি তীব্র ব্যথা থাকে তাহলে স্টেপ 3 থেকে হচ্ছে শুরু করা যেতে পারে। তারপর হচ্ছে যে আমরা ব্যথার এই ধাপগুলোর ক্ষেত্রে আমাদের যখন হঠাৎ করে যখন ব্যথা হবে কন্টিনিউয়াসলি আমরা ধাপগুলোর ক্ষেত্রে আপনার মুখের রুটে আপনাকে দেওয়ার ক্ষেত্রে প্রাধান্য দেওয়া হয়েছে।
Could you mute, please? There's a lot of backup noise from here.
MD Sohag Mia.
Carry on, Layla.
আমরা হচ্ছে প্রেফার করব যে ওরাল রুটের মাধ্যমে আমাদের যে রোগীদের ওষুধ দেওয়া এটা। আর ব্যথার ওষুধ যখন দেওয়া হবে তখন দেখা যায় যে মরফিনের ক্ষেত্রে বিশেষ করে আমাদের একটা টাইম মেনটেন করতে হবে। যেমন আমাদের এখানে উল্লেখ করা ছিল সকাল 7টা, সকাল 11টা, বিকাল 3টা, সন্ধ্যা 7টা এবং রাতের 11টা। এই ক্ষেত্রে 4 ঘন্টা পরে পরে আপনার ওষুধগুলো দেওয়া হয় মরফিনটা, কিন্তু রাতের বেলা যখন 11টার সময় দেওয়া হয় এটা ডাবল ডোজ দেওয়া হয়। এই পুরা কোর্স চলাকালীন সময়ে আপনার যদি হঠাৎ মাঝখানে রোগীর ব্যথা হয় সেক্ষেত্রে আপনার ওই যে আমাদের সিঙ্গেল যে ডোজটা এটা আরেকবার দিতে হবে, এবং পরের দিন এটাকে আবার ক্যালকুলেট করে এটাকে ট্রাইটেট করে দেওয়া যাবে, অ্যাড করে দেওয়া যাবে। যে যদি কারো বেশি প্রয়োজন হচ্ছে যে তার রেগুলার ডোজে হচ্ছে না তাহলে তার বর্তমান যে ডোজ থাকবে এটার সাথে যোগ করে দেওয়া যাবে। কিছু পার্শ্ব প্রতিক্রিয়া আছে মরফিন এবং ট্রামাডলেরও। এই পার্শ্ব প্রতিক্রিয়াগুলো নিয়ে আলোচনা হলো। যেমন কিছু বেশিরভাগ ক্ষেত্রে দেখা যায় যে আপনার রোগীদের কনস্টিপেশন হচ্ছে। কোষ্ঠকাঠিন্যের ক্ষেত্রে বলা আছে যে যাদেরকে এই ওপিওয়েড প্রেসক্রাইব করা হবে তাদের ক্ষেত্রে যাতে একটা করে হচ্ছে আপনার ওই কোষ্ঠকাঠিন্য কমানোর জন্য একটা ওষুধ দেওয়া হয় সাথে। এবং কি রোগীদের বমি বমি ভাব এবং বমি হতে পারে, ঘুম ঘুম ভাব হতে পারে, এগুলো থাকতে পারে। তারপর আমরা হচ্ছে একটা কেস নিয়ে আলোচনা শুনলাম। আমরা আরো ডিটেলস বিভিন্ন ডোজ এবং কি এগুলো নিয়ে শুনলাম। ট্রামাডলের ক্ষেত্রে বলা হয়েছে যে এটা শিশুদের ক্ষেত্রে নিষেধ করা। এবং কি এগুলো নিয়ে যাদের হচ্ছে রেনাল ইম্পায়ারমেন্ট থাকবে কিংবা কোনো সমস্যা থাকবে তাদের ক্ষেত্রে বলা হয়েছে ডোজটা একটু কমিয়ে দেওয়ার জন্য। আর টিপিএন এর একটা বিষয় উঠে আসছে, এটা নিয়ে হয়তো বা পরে আরো আলোচনা হবে। ধন্যবাদ সবাইকে। থ্যাংক ইউ জিলিয়ান।
Great, thank you, Ladha, for doing that. All right, we're just going to wrap up. We're on time. I just see that there's a question from Aaron. Is TPN available in the camps? So Leila or Tasneem, is TPN available in the camps?
মানে প্রোলিভ এগুলো আছে?
Yes, madam, it's available.
Great, thank you. And there's a comment from Nirosha. Please brief in English. I'd refer you back to the slide sets and the videos. So that's the English. Those are the English sessions. So okay.
Can I just add, Tasneem wrote something very nicely.
Yes, of course.
Yes, that that we will find out, which we mentioned, that we'll talk to the patient and think of a second caregiver who's going to decide for her.
Right, start with the substitute decision maker. Lovely, yes.
Thank you.
Okay, I think that Kathryn has posted again where all the course materials are on the Google Drive in the chat. Lovely. Okay, well, thank you, everyone. Thank you, Dr. Kathryn, Dr. Fatima, Dr. Romana, Lila, everybody who participated. The next session is a week today, and it's discussion of challenging ethical situations. So that will fit in really well because we talked about one of them today. Romana did, thank you. Kathryn, anything else you want to add, or anybody else?
No. Thank you, everyone.
Great, thanks. See you all next week.
Thank you, everyone. Good night.
Night.
Go to bed. Bye now.
Morning.